Good afternoon. My name is Ricardo Soares. I'm a urologist with Northwestern here in the West region. I was invited by the William Cancer Center in Geneva to talk today a little bit about a special procedure for prostate cancer. Prostate cancer is a very common cancer in men, and treatment can sometimes carry some side effects, including sexual dysfunction, so problems with potency. And I'm Portuguese, I've done my training back in Europe, and when I was there, it's in visits to Germany during my fellowship in England, I learned a technique we call NeuroSafe that is designed to maximize the preservation of the neurovascular bundles that run around the prostate, while at the same time not jeopardizing the cancer control during the robotic prostatectomy for surgery for prostate cancer. So, this presentation to give you a little more, some images for you to better understand what I'll be talking about. So, as you can see here, the prostate is has an meaningful relationship with the nerves, called the neurovascular bundle formed by nerves, arteries, and veins. They're extremely important for potency. And you see here these numbers 1, 2, 3, 4. These are the levels of nerve sparing that you can do during a prostatectomy. So the closer you go to the prostate, the more nerves you're going to preserve. Therefore, a better functional result you're going to have after surgery. But at the same time, you're somewhat risking adding a positive margin or leaving cancer behind. Of course, right now, for the last 5-10 years, we have the help of the MRI to help us know exactly where the cancer is or how extensive it is, so we can decide which one of these levels we should be doing in terms of to optimize the conjunction of cancer control and functional control. So you can see here on the left side of the screen, you can do what we call grade 1 nerve sparing, where there is no tissue other than the prostate that is being removed. This is grade number 2, where there is one of the levels of the fascia around the prostate is preserved. Number 3, there is some tissue, including blood vessels, that is removed. Number 4 is the most extensive, that is used for more advanced cancers, where there is pretty much all the tissue lateral to the prostate on both sides is removed. Of course, more removal, what's going to happen is the patients are going to have worse rates of potency after the surgery. And this is done to keep the surgical margins at a lower rate. So the surgical margin means that when the cancer is seen on the microscope, there's a positive margin rate when the cancer was reaching where the cut was done. And we need to keep this rate low so there's no risk of the cancer coming back. Of course, with more aggressive cancer, we need to do more of this grade 3 and 4 nerve sparings, because the risk, see in purple, this is the risk of the cancer actually going beyond the prostate capsule. If that is the case, we'll need to remove more tissue. Now, back in Germany, around 8-9 years ago, there was a technique developed in Germany, in Hamburg, at the Martin Clinic, where they started doing the surgery while the prostate, right after the prostate is being removed. It's still doing the surgery. The prostate is sent down to the pathology lab for biopsy, and they analyze the size of the prostate so that the area of the prostate is close to the neurovascular bundles. What they do, they start a microscope and they can see if there is cancer reaching the area where the prostate was cut and separated from the rest of the body. And you can see in this case, there was a little bit of cancer in this area, so the positive surgical margin, therefore it was required to remove extra tissue from the patient. I run here some of actually my patients, so I've been doing this technique since the beginning of the year here in the West region. So here you see an MRI, and you can see the red arrow. This is a dark area. This is where a positive biopsy showed moderate, intermediate risk cancer in 3 out of 4 cores. If you join the volume of cancer on the biopsy cores and the PSA of the patient, you come up with a risk of the patient having cancer going beyond the capsule. And this patient was actually 18% on the right. Of course, the further away you go, the safer it's going to be in terms of having a negative margin. So what I did, because I was able to do NeuroSafe in these patients, I was able to check the margins during the surgery. I did what would be considered risky 10 years ago, which would be to preserve the nerves completely here on this side, on the side with the cancer. But because I sent the prostate down for biopsy during the surgery, the pathologist was able to tell me that there was actually no cancer in contact with the cervical margin. Therefore, I was able to preserve all the nerves of this patient and at the same time getting all the cancer removed. This is another patient, so a lesion here on the right side. So again, cancer in 3 out of 4 cores. There was 16% risk of the cancer going beyond the capsule on this patient. Normally, you would go, so on the side without cancer, I did a grade 1 nerve sparing. On the side with cancer, I also did a grade 1 nerve sparing, because the NeuroSafe gave me the extra level of safety for me to be able to do that. And the pathologist saw, and normally they take about 20 minutes to give me the response, so it does not delay the surgery, so there's really no risk for the patient. And then, of course, this is a preliminary result. Then, although prostate is analyzed, it takes about 5 days, and it was confirmed that really the margins were negative. This is another patient, so a little different. So this patient had what we call a Peyer's 5 lesion on the left, so the highest grade of lesion on an MRI, so more suspicious for cancer. I took a targeted biopsy, fusion biopsy, and he showed lesion 7, so intermediate risk cancer in 5 out of 6 cores on the left. So left is actually the image on the right are inverted. In this patient who was already cancer going on, of course it was 24%, what happened? On the right side, I did a grade 1 nerve sparing. This was already on the patient. I wanted to really optimize its functional results. So I did grade 1 nerve sparing, but the pathologist told me that it was cancer touching where I cut. So 20 minutes after sending the prostate, I just went to remove some extra tissue from that side. That extra tissue had no cancer. And at the end, we could see the T3A means that the cancer was going beyond the capsule, but the margins were negative. So what happens with NeuroSafe is that we're able, instead of having, see on the left, 19% of the patients were actually having no nerve strain whatsoever, and by the introduction of NeuroSafe, that 90% turned into only 3%. So more patients were getting nerve sparing procedures. Now, only 2.5% of the negative NeuroSafe, so the intraoperative frozen section, that information that the pathologist will tell me within 20 to 30 minutes, in 2.5% of the cases where they tell me is negative, there is a risk that on the final exam, it could come out as positive. This 2.5% is extremely low, so it's something that we can be really comfortable with. At the same time, that extra tissue that is removed from the prostate, in only 20% of the cases, is carrying cancer, which means that most of the time, actually, no cancer is really left behind. It's just the margin was positive because it was just tangential to where the cut was done. Now, by doing the NeuroSafe, in this is a series from 2012 from Germany. There was a 7.8% decrease in posterior margins in all the patients. This was particularly relevant in patients who had more aggressive cancer, where normally you would not do a nerve sparing, but even doing nerve sparing, we're able to reduce in 18% the risk of negative margins. of those margins. So you can see here on the final specimen, with neurosafe procedure, we're able to have less possible surgical margins, and therefore improve the cancer control of these patients. And what we can see in this chart is just to show you that the fact that, so P2 is when the cancer is contained in the prostate. So the fact that we preserve more nerves, so being neurosafe, does not impact the recurrence of the cancer. So it's completely safe. Same thing for patients who have T3A, so when the cancer is going beyond the prostate capsule, and due to neurosafe, we're able to have more of these patients getting nerve preservation, but there is no difference in terms of cancer control. So you have the good side of nerve sparing without having the downside. Also here we call it about the converted surgical margin. So this is like the third case I showed you today. So when the neurosafe comes out positive and we remove some extra tissue, we could see that the final negative margin, even if it's converted or if it was initially negative, those patients have the same cancer results in the long term. We're talking here so 60 months, about 5 years after the surgery. So I conclude just to say that this is a procedure that does not extend the time of the surgery. It is completely safe for the patient. It doesn't change your post-op recovery, but it will definitely increase the functional results, particularly in terms of sexual function, without jeopardizing the cancer control. And now we'll be able to answer some questions if anyone from the audience.
So it sounds like any patient experiencing prostate cancer is a potential candidate for this, correct?
Correct. Potentially, yes. But what happens is that, for example, tomorrow I have 2 cases. One of the cases I'm going to do this procedure, it's a younger gentleman, potent, with where I want to really optimize the preservation. The other gentleman is older. He is not interested in so much into his functional results, and his cancer is more aggressive.
Okay.
So in that case, probably it's not worth it because I'm going to optimize cancer control, therefore not preserving so much. But potentially, yes, every single patient is okay.
And how many surgeons are in this area that perform this type of surgery, the NeuroSafe?
To my knowledge here in the West region and the Western service, I think I'm the only one performing it, but other people might be doing, but not to my knowledge.
Okay. And what about just within the U.S.?
There are.
There
Even in Chicago, I know that this is done at Northwestern in Chicago.
Mm-hmm.
But and elsewhere in the U.S., yes.
And I think last question, what are the risks with this particular procedure? Is it any different than having prostate surgery, adding on the NeuroSafe?
No, the surgery is the same. In a way, it will just increase it. Because you're going to give me information about the surgical margins, then normally I would only get 5 days, 5-7 days after the surgery. Right now, I am getting information live during the surgery when I can still do something about a posterior margin. So, if any, there's only an increase in it. The surgery itself is no different. So, it's something that the patients should have no fear of going ahead with something like this.
And why do you think it's not more widely available?
So, first there's one thing is that some people did not have contact with us, so some surgeons are not aware of the possibility. I had that experience that we're doing this back in England, so I'm used to it. I was able to talk with the pathology department here at Northwestern. They were excellent. They worked so hard, and I'm so grateful for their work. They're fast and efficient, giving me the response without delaying the surgery. So it depends on the surgeon, but also having an efficient pathology department.
No more questions.
nice evening. Thank you for watching.